Benioff Medical Center, pulmonologist. So as you know, bronchoscopy is an important tool we use in the ICU almost on a daily basis. You probably see it most often to clear secretions or blood clots or something like that. But today I'm going to talk more about more advanced type of procedures with the aim of trying to get people off ventilators sooner and intervene when you're stuck. And so I'm going to speak about central airway obstructions in foreign bodies. Spend some time on hemoptysis because we've had a lot lately of intubated patients in the ICU with significant hemoptysis. We'll talk about how to speed getting someone's air leak to resolve using endobronchial valves. And I'm going to give you some examples from some cases. I'll run through the slides a little quickly, but I'm not going to read them to you, but I'm going to kind of summarize each one. So we'll start off with central airflow obstruction or airway obstruction. And this is primarily in the central airways where the trachea or the right or left mainstem bronchus are occluded by something, often tumor, but can be blood clot, can be foreign body. And so it's a common problem for people with lung cancer, and they can get stuck on a ventilator without an intervention. So we can use therapeutic bronchoscopy, either flexible or rigid, most often flexible, to try to relieve the obstruction. And we use various methods to do that, which I'll discuss, such as argon plasma coagulation or cryotherapy. Which you choose can be up to the operator's experience or the clinical situation. If the patient's on a high FiO2, for example, I won't be able to use a laser or I'll create an airway fire. So you have to be a little bit careful what you choose to use. And as I mentioned, the whole idea is to relieve the obstruction and get them off the ventilator faster. So what are some of the tools? We use forceps and baskets to get foreign bodies out. Sometimes you can snare something or lasso it. I like to use argon plasma coagulation or ablation. Sometimes we'll stent the airway open if it's being collapsed by external mass. I use the cryo quite a bit to debride and take out chunks of tissue that are blocking the airway. Sometimes we use a cauterizing snare if something's on a stalk or a polyp. We also utilize balloons. So you can blow up a balloon to try to increase the airway, or stick the balloon past an obstruction and lift the obstruction out. So balloons are kind of fun. So here's some pictures of the baskets we may try to, put around a foreign body and lift it out. There's some different types of forceps are useful. It kind of depends on what you're up to and what you're trying to get out. Snare can be a little bit tricky, but if you have something soft and you can, but not friable like a clot, you can utilize the snare. Cauterizing snare, I like this, like I said, when there's like a stalk or a polyp, because you can go to the base of it and basically tighten your noose while you're cauterizing it, so you stop the bleeding and remove the mass at the same time. APC is a commonly used method of ablating tumor. I like APC because it's relatively safe. It doesn't penetrate super deep. It's a great thing to control bleeding if you can see the site of bleeding. So if you have someone with an endobronchial tumor that's bleeding, you can spray your APC around it and just cauterize it and stop the bleeding. That's unusual. Usually the bleeding's coming too distally and I can't get to it with the APC. Cryotherapy. So this is the idea with cryo. You're using the tip of your catheter to freeze to whatever it is you're trying to remove, be that tumor tissue or something you just ablated, or a foreign body if it's organic. Cryo doesn't always work in certain situations. But the beauty of cryo is it doesn't matter if the patient's on FiO2 100%. So we can use lots of cryo when they're really sick. This is what a cryo probe looks like. So here's some photos of us using the cryo in a bronchoscopy case where we'll navigate out to a peripheral lesion and then put the cryo probe out, a little one, out into the periphery to do a biopsy. So you can get a nice chunk of tissue, as you can see in the middle there, when you want to do a biopsy. So like I said, you're freezing to what you want to remove. It works really good for organic material. So if somebody aspirated a piece of apple or something, it'll freeze to that nicely. But it's not so good if the thing is plastic or non-organic. So if they aspirated like a marble or a tack or something like that, something metal, it doesn't really freeze well to metal. But it does work really well for debridement of tumor. You got to be a little careful with it because it does take a big chunk and you can cause significant bleeding. So you got to be prepared to deal with that if it happens. This is just basically the machine that we use to do the cryo along with APC. I mentioned you could use balloons. So there's an example of balloon bronchoplasty on the right, and on the left, lifting out a foreign body out of the airway. Sometimes you just can't grab something with forceps, or you can't freeze to it with the cryo, so you got to come up with another way. So Ernst's group published this article in Chest saying that we're all at an Experience Institute, you're pretty successful at relieving the central airway obstruction with these methodologies. So if you have people that are trained to do it, it can be a good way to get somebody off the ventilator. And the complication rate is reasonable. It's not zero, but probably mostly bleeding. So again, like I said, these type of procedures of relieving the central obstruction can get patients off the ventilator faster, and that's what we're trying to do. Stenting. In the old days, I think people did a fair amount of rigid bronchoscopy to place stents, especially for central airway obstruction. I do them with the fiber optic flexible bronchoscope. And for tumors that, and we did this a week ago, that are central and you're worried about the airway, like a big mass in the distal trachea, if you just go down there and start mucking around, you could easily find yourself in a very bad situation. And so I'll do these on veno-venous ECMO. So you heard about ECMO, veno-venous ECMO earlier. We actually started doing procedural veno-venous ECMO when we're worried that we're going to have a problem with gas exchange. So last week we relieved a distal tracheal tumor on VV ECMO, and patients effectively removed from the ECMO and extubated the next day. You can use stents also for tracheal malacia and some other types of disease like granulose formation. But generally, most of these patients that we're stenting are people with tumor that's invading the airway, be that metastatic or primary lung cancer. There's different types of stents. Traditionally, the silicone type ones would be placed with the rigid scope. I like to use the new nitinol type stents that are flexible. They can fit through the scope. If it's a really big stent, like a tracheal stent, we use a guide wire and fluoro to mark where we're going to put the stent. So there's some different strategies for doing that. So here's an example of how we deploy just a nitinol self-expanding stent. Sometimes I got to do a little bit of laser beforehand to open up the airway and then put the stent. If the tumor mass is completely around the airway and there's nothing on the inside of the airway, I just do the balloon bronchoplasty and place the stent. These are some examples of silicone stents. This is a patient that was in the ICU, a young man with mantle cell lymphoma. And what we're doing right now is we're at the main carina looking down the left main stem bronchus. So he had respiratory failure and a compromise of his left main. Basically, whenever he exhaled, the whole thing would just collapse. So we put telescoping stents. This is the distal stent after some ballooning, and then proximal stent. And finally, at the bottom, you can see the final stent at the level of the carina. Foreign bodies, I mentioned some of the techniques to get them out. Something like this, a seed, a large seed like this, hard capsule, really hard to grab with forceps. And I think in this case, we tried to use the cryo and it just wouldn't stick to it. One thing you could try to do is scratch it up with the forceps and then try the cryo, or just put the balloon distal to it and lift it out. This is a pretty funny case. So this is a patient that I did a bronchoscopic biopsy on, and this is his post-op x-ray. So there's an arrow pointing to the area that I biopsied, but there's another abnormality on this x-ray that was missed. So he gets treatment for the tumor we diagnosed and comes back 6 months later, gets a CT scan to see how he's responding to treatment. And then again, there's a opacity in the right mainstem bronchus that's refracting. You see it on the x-ray now? So we went down there to get it, and it was his tooth. So when they intubated him for the bronchoscopy, they knocked off a tooth. And it went down the right main, and he didn't tell anybody. So we didn't know until we saw his CT scan. But actually, when I looked back, I saw it on that x-ray. We missed it. So that one, the teeth are hard, right? Because they're really smooth, and it's hard to grab them. It'll just keep slipping off. Cryo doesn't stick to it that well. And so what we did was turn it upside down where the roots are and grab a root and then pull it out. Yeah. This is a patient with really bad cancer obstructing the right middle lobe and the right lower lobe. We're looking at it from the RBI. So we used APC and balloon to open up those airways and got the patient off the vent. Moving on to hemoptysis. Most of hemoptysis that I see is benign and not a big deal, usually bronchiectasis and scant hemoptysis, but it can get serious at times and life-threatening at times. The most common etiology actually worldwide is TB, but here in the islands, it's probably cancer and bronchiectasis is what I see the most. We do see some diffuse alveolar hemorrhage as well. So how to define it? People try to say what is massive, what is non-massive. They'll say a liter is massive or 250 mil is massive. But really what I believe is it clinically significant? Can the patient keep up with it? Is their gas exchange being affected? Is their work of breathing being affected? If it is, I would call that serious hemoptysis that has to be addressed. So again, yeah, it's hard to calculate the amount that they are actually losing. But they can quickly, especially if it's a patient like with bad emphysema or COPD, they have little reserve to tolerate a lot of blood in the airway. You start clotting off a lobe or getting out atelectasis, and they're going to be in a lot of trouble. So you got to have respect for those who have underlying heart disease or lung disease when they're in this situation. And so bronchoscope, I think it's helpful in determining where's the blood coming from. You may not be able to intervene if it's distal. If it's diffuse alveolar hemorrhage, the bronchoscope is only going to help you remove clots. It's not going to do much of anything else for you. Here's a patient that was in our unit with a bad pulmonary histoplasmosis infection. He had a diagnosis, but didn't take the antifungal like he was supposed to. and wound up in the ICU again with massive hemoptysis and hypoxic respiratory failure. He had to have a bronch 8 times to clear out all the blood out of his airways. So here's an X-ray and an example of what his CT looked like. So in this case, you can see a whole lot of blood clot, including all the airways. That's going to affect your gas exchange. And indeed, he kept on desatting, and the team was talking about tracheing him. So we used cryo to remove some of it, but the cryo is slow and laborious. It'd be in there for hours trying to get all this clot out of there. So I asked for this thing. This is a suction device that is hangs out in the OR, and you can really crank up that suction way higher than your ICU wall suction. And you could probably get out a foreign body with it if you wanted to. But you got to be a little careful that you don't suck the lung out too, because it's powerful. But with that device, we were able to clear all the clot instead of sitting there trying to freeze to it for an hour or lavage it and suck it out. It's miserable. So another aspect that we should be aware of is embolization. The vascular system for the lungs comprise a bronchial artery and pulmonary artery. Pulmonary artery mainly does the gas exchange. Bronchial is what supplies nutrients to the lung tissue. And it's usually the bronchial arteries that cause the massive hemoptysis. And so you can ask your interventional radiologist friends if they're able to embolize it. They may ask you, the bronchoscopist, to tell them which lobe. So you may try to go figure out, is it right upper lobe? Is it left lower lobe? Where is the bleeding coming from? So it gives them at least a little clue. People who have massive hemoptysis can die in the unit. So embolization has become a pretty important tool when the bronch can't do anything. And sometimes we do them together. As I mentioned, the most common cause worldwide is TB. We see plenty of TB here, but mostly bronchiectasis. One more caveat that's important to remember is if the patient's becoming unstable, you're going to need to intubate them, but don't intubate them with a 7.0 tube. You're going to need a larger tube to get the therapeutic bronchoscope through. So remember to put in a larger tube. Another technique, at least acutely, you can try to main stem the side that's bleeding and try to main stem away from the side that's bleeding to try to preserve the good lung. Put the bad lung, the bleeding side down, let gravity help you keep the other lung from getting affected, and then we can bronch. Another strategy, if you've got a thoracic anesthesiologist handy at 12 midnight, is to put a dual lumen endotracheal tube where you can separate the two lungs and ventilate one side differently than the other, or block one side of the other. And I'll show you some of that technique. You can put these balloon occlusion devices down, and you just need a special little Portex. And some of them even have a little hook you can grab with your bronchoscope forceps and guide it down to the area that's bleeding. Hopefully you can see, because it can be hard. So here's an example of one where it has a loop on the end that you can kind of put your scope into and guide it down, or grab it with forceps and guide it down. And then occlude the site that's bleeding until you get control of hemostasis or correct their coags or whatever the issue is. A couple of days of antibiotics and steroids, and come back and take it out and clean up. Hopefully your patient can tolerate that, because a lot of them don't, like I said, don't have a lot of reserve to tolerate losing a lobe even. Frequently, when I get bleeding in the OR doing procedures on people, I just use cold saline or topical epi. Cold saline works pretty good, actually, if you use enough of it. There's other agents that have been tried, vasospastic agents. I haven't tried those, but I do use epinephrine. So topical epinephrine helps. Sometimes I'll ask for the laser if I can't get it under control. And then there's tranexamic acid, which has come on the block recently. This was originally created for women with menorrhagia. So the OB-GYN people came up with this. And then the other surgeons caught on and said, hey, this is a nice tool to stop bleeding. So it started being used in all kinds of settings. And then more recently, we've been using it in the hemoptysis setting. Mostly you see us nebulize it 3 times a day. It's not cheap, so we try to not do it excessively. But there's other ways to do it as well. The earlier trials, they were trying to do it IV, but it didn't work as well for hemoptysis. And I think giving it topically or nebulizing it is probably a better route for the patient with hemoptysis. Yeah, we've done some endobronchial installation also for bleeding. Your anesthesiologist may have it on the cart in the OR. I don't know that you keep this in your ICU though. You may have to order it to do that. And we talked about embolization being successful, 73 to 100% successful. So make friends with your interventional radiologist. Endobronchial valves, I'm going to talk more about that in a minute. Kind of an interesting strategy. I haven't done this yet for someone that's bleeding, but instead of putting a balloon occlusive device, you could drop a valve if you see the subsegment where the blood is coming from. Come back in 4 weeks later, take it out, clean up. And for those who you try all these things on and it fails, your last option is surgery. A lot of the time, these patients are too sick and the surgeon's going to say no. But in select cases, maybe they've got like a big fungus ball that's causing the bleeding. Maybe the surgeon can go in and take out a lobe and stop the bleeding. If they're otherwise, their performance status is decent. So lastly, endobronchial valves. This is a fun little tool that's come along recently. There's 2 types. One, it depends on their coating. One is, I think, silicone. The other one's polyurethane. So you can see a picture of one at the bottom there, deployed inside the lung. So they were originally approved for lung volume reduction, which we do a lot of, and then the trials look good and the outcomes are good. But then we started doing them for persistent air leak. So here's a chest x-ray showing a large right-sided pneumothorax. Now you can see a chest tube has been placed into that pneumothorax and some pretty diseased lung. And then the one on the right, you can see a valve has been deployed and the lung is expanded. So yeah, we put these endobronchial valves to stop the air leak. So we've been doing this for 20 years, but I myself have only been doing this for 10 years. Like I said, it was really approved for lung volume reduction. So you kind of have to have your IRB sign off on this at your institution that you can do this. So here's a picture of the 2 valves, different valves being deployed. And I think on the right side, you can see a nice picture of what the valves look like on an x-ray. So they block ventilation distally, or at least slow it down, but they allow secretions to come forward and get cleared. So the idea is you're having less air, keeping that hole in the lung open, giving it a chance for the sides of the holes to oppose each other and heal. And so I've rarely seen this work like right away. The leak is gone and you're done. Usually it takes a good 3, 4, 5 days for the leak to stop. And then you can start working on getting your chest tube out and getting the patient extubated if they're intubated. There's different size valves. We use a special balloon to measure the size of the airway to choose the size of the valve. That's probably detail you don't need to know. So you got to be a little bit careful in some patients because they can get hypoxic, especially if they have really bad emphysema. So keep an eye on that. Other ways to figure out where to put the valve. So like I said, we're measuring the valve sizes, but when I first go down, I have to find out where's the leak. So I occlude a big balloon proximally to see, okay, it's in the left upper lobe. Can I figure out the subsegment or not? And if I can't, I'm going to deploy multiple valves. Like I said, they're both made of nitinol. They have different coatings. They come in various sizes. Pretty easy to deploy, low complications. I've never seen one migrate, but I guess they could. And you can get pneumonia behind them. Sometimes you deploy them and it doesn't land right and you have to reposition it or take it out and do another one. So not always easy. Plenty of data out there to show that these things do reduce the time of the air leak and get the chest tubes out faster. So in conclusion, I think the bronchoscopy is an important procedure for ventilated patients. Like we've just shown, you can remove obstructions of the airway, treat hemoptysis, treat persistent air leaks. So it's not only just clearing secretions and putting perk trachs. There's lots of things we can do with the bronchoscope in the ICU. Thank you.
So much, Dr. Evans. Any questions for Dr. Evans?
Do they use bridge bronchoscopy anymore?
Some institutions do. Yeah, they do it. Well, now, so when I trained, there were interventional pulmonary fellowships, but now you do an extra year and you can do an IP fellowship and they'll train you to do it. And the thoracic surgeons are trained to do it, but I rarely see anyone use it because our tools with the flexible scopes are so good now. Yeah.
To remove secretions from the airways, nurses respiratory therapies actually rarely touch it. Do you think that it plays in the future, perhaps, for them to use small room and bronchoscope and actually see what they're doing?
Yeah, possibly disposable scope could be used by the RTs. That's probably some turf battle and credentialing battle going to happen there.
Expenses too.
Yeah, billing and charges. I mean, there's definitely some situations where the physician needs to look at the patient and decide, is it actually safe to do the bronchoscopy or not? So sometimes I just say no because I don't want to kill the patient.
My question is, what's your view on just doing a bronchoscope versus having an RT do a mini valve?
I think mini valve's a reasonable thing to do if you know where you are. I think I like doing the scope and having the CT so I know exactly where I need to go to do that lavage and I get it from the right spot.
Thank you so much, Dr. Evans.
Thank you.